Welcome to this on-demand video, which will address action as one of the 4 outpatient core elements as defined by the Center for Disease Control and Prevention, also known as the CDC. The primary goal of this project is to increase the number of outpatient settings that have incorporated all 4 core elements of outpatient antibiotic stewardship, and we will be releasing a video per month until all elements have been discussed. The core elements themselves, as well as the tools and strategies for implementing or enhancing them, will be the focus of this presentation. Specifically, we're asking for emergency departments, emergency services, urgent care centers, physician offices, clinics, and community pharmacies to view and implement at least one of the strategies discussed today. My name's Deanne Richards, and I'm an infection preventionist project specialist with the Lake Superior Quality Innovation Network that serves Michigan, Minnesota, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. The core elements of outpatient antibiotic stewardship provides a framework for antibiotic stewardship for outpatient clinicians and facilities that routinely provide antibiotic treatment and were developed through a combination of combining and consolidating evidence-based antibiotic stewardship practices and building on or adapting best-known practices for antibiotic stewardship across other clinical settings. In September, I reviewed commitment as one of the first elements of the core. If you did not have an opportunity to view this video, you can access it through the webpage www.lsqin.org/initiatives/ASP/. Today's topic is action for policies and practices. How does an organization show action for antibiotic stewardship? I would make the following suggestions. Using evidence-based diagnostic criteria and treatment recommendations provides best practices to follow, as well as supports clinical decisions. Clinical decision support, which provides specific information in electronic or print form during a typical workflow, can facilitate accurate diagnosis and effective management of common conditions, such as discouraging antibiotic prescribing for acute bronchitis in a healthy adult. Community pharmacies should call the prescriber if the order does not appear to follow standards to seek clarification. In addition, the pharmacy can provide support to that prescriber. Outpatient pharmacies can also have a list of recommendations of over-the-counter medications based on practice guidelines to help establish a clear expectation that antibiotics are not always the answer. Delayed prescribing can be used for patients with conditions that usually resolve without treatment, but who could benefit from antibiotics if the conditions do not improve, such as acute uncomplicated sinusitis or mild acute otitis media. Clinicians can apply delayed prescribing practices by giving the parent or the patient a post-dated prescription and providing instructions to fill the prescription after a predetermined period, or by instructing the patient to call or return to collect the prescription if the symptoms worsen or do not improve. Community pharmacies should verify the prescription date and, if post-dated, offer to hold the prescription and provide the pharmacy phone number to relay if the script needs to be filled. Watchful waiting means providing symptomatic relief with a clear plan for follow-up if infection symptoms worsen or do not improve. Watchful waiting and delayed antibiotic prescriptions are evidence-based approaches that can safely decrease antibiotic use when used in accordance with clinical practice guidelines. Community pharmacies are often filling this role by seeking to understand the customer's signs and symptoms of illness and suggesting over-the-counter medications which will help them feel better. Communication skills can be used to promote strategies to address patient concerns regarding prognosis, benefits and harms of antibiotic treatment, management or self-limiting conditions, and clinician concerns regarding managing patient expectations for antibiotics during a clinic visit. Requiring documentation justification in the medical record for non-recommended antibiotic prescribing has been shown to reduce inappropriate prescribing by holding clinicians accountable in medical records for their decisions. This, when paired with education, has found to be effective in changing prescribing practices. Utilizing call centers, nurse hotlines, or pharmacist consultations as triage systems to help prevent unnecessary visits can be used to reduce unnecessary visits for conditions that don't require a clinic visit, such as common cold. This also frees up the provider in the clinic to see patients who need more immediate medical treatment or monitoring. Additional ideas you may want to consider besides what I've already discussed include reviewing for duplicative antibiotic therapy orders, both at the clinical and pharmacy level, such as having 2 anaerobic coverages with pip/TAZ as well as metronidazole. Medication safety through renal dosing adjustment requires regular clinic appointments and timely review of labs to update prescription orders. Clinic and pharmacies will need to provide ongoing education to patients or customers on why the dosing was changed and verify they understand new directions for use. Ensuring that contamination does not occur at the time of the culture avoids false results and then in return avoids inappropriate antibiotic treatment. Staff need to be knowledgeable on adverse events associated with antibiotics, including signs and symptoms to teach patients or customers. This is important in the area of Clostridium difficile, also known as C. diff. Having them understand when they need to call the provider back or immediately if they developed acute, abrupt diarrhea that does not resolve. Antibiotic timeout, or the process of re-looking at the case of any patient who is prescribed antibiotics 24 to 72 hours earlier, allows for de-escalation of medication by narrowing the antibiotic focus after culture results are back and or after having a call with the individual to see if they're responding to the current treatment plan. Although the core elements provide a framework for outpatient antibiotic stewardship, implementing the elements requires a thoughtful and consistent effort to achieve desired outcomes. This includes developing strategies and preparing individuals, facilities, or organizations for change, developing and testing stewardship interventions, identifying and addressing barriers to change, and evaluating progress towards stated goals. Outpatient settings remain a crucial component of antibiotic stewardship in the United States. Establishing effective antibiotic stewardship interventions can protect patients and optimize clinical outcomes in the outpatient health care settings. LSQIN participants are encouraged to refer to your toolkit, which includes additional information on action. Individuals outside of Michigan, Minnesota, or Wisconsin are encouraged to contact your own local Quality Innovation Organization, or QIO. Thank you for joining me today. We hope that this information has been useful and you will be able to implement one of the discussed items today. Thank you and have a wonderful day.